Hello and welcome back to Medical Associates Health Check. I am Dr. Christopher Bristow. I'm the founder of the Concierge Medical Clinic and I am a specialist physician in internal medicine. And today, with me, my co-host.
Hi, I'm Dr. Laisha Selvaraj. I'm the clinical administrator for Medical Associates Hospital.
And today we'll be dealing with some really sensitive topics
Mhm.
surrounding women's health and, gynecological issues that, would obviously affect women. And we have none other than Professor Samuel Ramsawak. He is a renowned obstetrician and gynecologist.
Oh, thanks very much, Laisha and Chris. It's a pleasure to be here. You know, fertility, I look at it like a table with four legs, and each leg has to play a role. Number one is what about fertility related to lack of ovulation? A woman has to make eggs, and if they're not making eggs, that's one. Number two, can the eggs get to the sperm? So they have to go along the fallopian tube. Can the tubes be blocked? Number three, are there conditions which affect the implantation site, like uterine fibroids? Fourthly, and probably most importantly, the one which will prevent that table from standing is the lack of sperm or lack of adequate sperm. So there is that male factor.
We see a lot of women with painful periods and what we call dysmenorrhea. And I am sure that you see this quite commonly. So, could we talk to you about how to manage these ladies that have painful periods, what the common causes are?
Okay, so painful periods, of course, very common. It is not, first of all, it's not unusual, and it doesn't necessarily mean something is wrong. Getting pain with a period, for example, on the first day and possibly into the second day is quite absolutely normal. And it's caused by the breaking down of the tissues to form the period that's coming out of the uterus, and that's associated with a particular substance called prostaglandin. So the simplest thing to do is, use your normal, simple home remedies, hot towels, and just having a quiet day, maybe not going to school, not going to work, if it came to that, but also using a tablet like aspirin or maybe one of the non-steroidal anti-inflammatories. Subsequent to that, we see people who have painful periods which have a different kind of persona. So they start generally before the actual flow. So they start maybe a day or two before, maybe 5 days before, with some kind of cramp or some kind of pain. And then the pain continues into the menstrual flow. And if the flow is for 4 or 5 days, it continues for those days. And we usually call that secondary dysmenorrhea. In other words, there's a secondary condition. And that secondary condition would be where we have a number of things that can affect fertility.
So we have to really look into investigate those patients where the periods are a little atypical or unusual and the pain is lasting a little longer. And those patients might pop up. A GP doctor might see them first.
Yeah.
Might obviously come to a specialist, but they might see their GP doctor and get painkillers. But beyond the painkillers and stuff, any role for any other testing, blood tests,
So yeah,
ultrasounds,
sure. Well, we need to try and determine what we're looking for. So the common causes would be things like fibroids, which are growths within the muscle of the uterus, or something similar to that is another condition called adenomyosis, which is where there's bleeding inside the uterine muscle, and that's related to another pretty common condition now called endometriosis. Endometriosis has come so familiar to women who have painful periods. Everybody calls it endo because they figure, and everybody knows endo is bad.
Yeah.
Trending.
It's very painful, and it's caused by bits of tissue that would normally be within the uterine cavity that spread via the fallopian tubes into the pelvic cavity and take up residence on the ovaries and the pelvic area and the bladder and the intestines. And every month there's bleeding occurring from these tissues. And of course, that's extremely painful because it has nowhere to come from to go to. And actually, by bleeding, it ruptures the tissues where it's bleeding from. So endometriosis is a big problem, and also there's something called pelvic inflammatory disease,
Right. Yeah.
commonly called PID, which is when there's some kind of infection within the pelvic cavity, and that also causes pain at periods. So we have to look. But one of the most important things when looking is to examine. So you take a good history, you find out whether it looks like primary dysmenorrhea or secondary dysmenorrhea, then you do an examination. That examination will include an examination of the abdomen, but also an examination of the pelvis.
Right.
But the big thing here, a big investigative tool, is a pelvic ultrasound.
Yeah. So, Prof, like how some of these conditions you just mentioned, how could these conditions affect, or what other conditions might affect a woman's fertility?
And really, one of the crucial aspects of fertility is related to the male factor.
Right. So when we come back from our break, we're going to be exploring more about fertility, what the man's role is in fertility. So don't go anywhere. Come right back.
Medical Associates Hospital is the most affordable MRI imaging center in Trinidad and Tobago. Patients have quick access to bookings and service, on-time appointments, high-quality, convenient, and fast scans. With $800 off all MRI scans, we guarantee we have the most affordable MRI service in Trinidad and Tobago. Medical Associates Hospital, #1 healthcare for the entire family. Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates' gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, #1 healthcare for the entire family.
So, welcome back. So, in this segment, we will be switching it up a little bit and bringing in the fertility and infertility aspects of the discussion. So, Prof, men don't always like to take blame for infertility, but there might be a component of infertility that might be related to the men, not so?
Yeah, and I mean, Chris used the word blame, and we try to avoid that term. But I mean, often, unfortunately,
I use it for
this-
spite because I
yeah.
know that's what we get.
Yeah.
Blame.
But unfortunately, it so happens that the women get blamed.
Not true.
And
Yeah.
in many societies, and including ours, there's a major emotional impact of not being able to get pregnant.
Most definitely.
And we have this type of extended family situation where mother-in-law
Oh, go.
Yeah.
That is it. Stuff.
is wanting to know why this baby is not coming,
Yeah, for sure.
and would not at all imagine it's a son. Yeah.
Yeah.
So we have to, bring some focus onto the male, for the simple reason that it's well proved that maybe 40 to 50% of instances of inability to conceive is related to what we call a male factor. So the man, #1, has to have a sperm, must have a good lifestyle, must be there at the right time for achieving the pregnancy, must be willing to do what we say have regular sexual intercourse, which would be 2 or 3 times a week if you're trying. Would be smoking.
I was going to ask you about lifestyle factors.
Yeah, we know that can affect the ability of sperm to function.
Prof, what about I hear these little myths about men and tight underwear. Is there any
Yeah.
correlation between that and
Yeah. Okay. So there's a reason why the testes are outside the body.
Right.
They're
Right.
outside the body because they're meant to be kept cool, and we live in a tropical climate, and if you add to that tight underwear, nylon type underwear, non-breathable, plus jeans,
Pressure.
it could be some difficulty.
Literal pressure.
pressure?
Yeah, exactly. So we like to recommend to men that they wear loose clothing, loose underwear, cotton underwear if possible. But it's not the only thing. There are so many other things that affect a man's fertility. We just mentioned smoking, but of course, you have to think of any infections that the man may have acquired that may block the tube that brings the sperm from the testis to the outside. Certain chemicals, maybe in.
What about alcohol, Prof?
Yes, I think it depends on the I mean, in moderation, I don't think there's an issue, but one has to always look at a healthy lifestyle, so to speak. I don't ever tell men to not drink. I think there's a number of units. That's the term they use to quantify how much alcohol might be permissible, but it's not a total ban.
Yeah, so Prof, like when you're trying to get pregnant, you're going in as an army, right? You have a battlefield, sperms coming all the way in, but now we're switching up from the male side, delivering the sperm to the female. And the female now has an environment that could be hostile for whatever reason that could affect fertility. Can you elaborate on maybe some infections that might pose a risk or to the fertility status of a woman, or other things that may change?
Well, I haven't heard it called a battlefield before, but it's a nice, concept in a way. Yeah. But the truth is that there are so many things that can affect the successful fertile window in a couple, and of course, infections, you did mention. Infections can affect the man as well as the woman. And the commonest infections that cause problems would be something called chlamydia and another organism called gonococcus, so you would have heard of gonorrhea, and others as well. But those are the two that actually often block the tubes and prevent the sperm from either being ejected or if their sperm just get into the woman's pelvis, cannot get into the tubes to reach the eggs, and that is a big problem by and large, and therefore we will test for the tubes. We will find a way to determine if the tubes are open or blocked, and that's generally by doing an X-ray or something called a laparoscopy, which I think is very topical. It's a minimally invasive type of surgery, and I think that if women were looking at becoming fertile, one of the things they need to know is to understand their body and their body functions better. And one of the ways to do that is to determine when am I likely to be releasing this egg, the so-called fertile window. And what is happening is that the egg is developing in the first 2 weeks of the cycle, and it has to be released at a certain point. And what allows it to be released is the production of a hormone called LH, which is a luteinizing hormone, and that is so-called ovulation hormone. When that is being produced, it causes the egg, which is in a little sac, to mature and for the sac to rupture and release the egg, and that is called ovulation. And that therefore gives us an important window as to when's the best time to try. Because what I have found is sometimes people try a little bit too much, so they're trying when an egg is not there, and therefore by the time the egg gets there, most of the sperms have been used up. Bearing in mind that sperms take maybe 3 months to form. So one has to be, you have to do this thing, as they say nowadays, they say work smart, right? So you figure it out, when the best time is for fertility, and then you become active. Yeah.
So there is fun in trying, but
absolutely,
you gotta make sure your timing right.
Sometimes you have to apply a little science.
Prof, there is the fertile window that we've talked about. How can our patients know when their fertile window is?
Okay, so first of all, you have to look at the cycle length. What's your normal cycle length for you? Is it, and we're talking here from the first day of the cycle to the first day of another one. And if that's 26 days or 28 days or 30 days, there's no magic number. right? But it could be up to 35 days, for example. Then you can have an idea of when that egg might be coming out. How do you know? You look at the cycle length and you subtract 14 from it.
Okay.
So if the cycle length is 30, you subtract 14, you get 16. So we're thinking maybe around day 16. If it's 28, you get 14. And therefore you have to, but you also have to say, look, could it come a little earlier? Yes. Could it come a bit later? Yes. How do you know? Well, there are some signs that can be used, and one of them is the production of a mucus by the from the vagina, and often women will monitor that mucus. We don't expect in a 28 or 30-day cycle that ovulation will take place before day 11. So often we say to women, start looking from day 11 for this mucus. What are you looking for? You're looking for a mucus that's like egg white. And it's egg white because it's clear, it's got a lot of crystals in it, it's got a lot of salts in it, and therefore the sperms can easily penetrate that mucus. After ovulation, the mucus becomes thick, and sperms cannot penetrate that because you don't want additional sperms after ovulation. So number one is the mucus. Number two, there's a urine test that can be done as a home test where you look for that same hormone we mentioned before, which is LH. And if you start testing in the urine from day 11, you're looking, it's very much like a pregnancy test where you're looking for one line or two lines. If you see two lines, normally for pregnancy, that's you're pregnant. Yeah. If you see two lines with the LH test, it means that you're likely to be ovulating because that ovulation hormone is now being picked up by that test. So it's a very simple test, just like a pregnancy test. You collect some urine in the morning, you put the stick into the urine, and then you put it on a table for 3 minutes, and you look to see if you see one or two lines. When you see that, it means that hormone is being produced. We expect the ovulation to happen, the actual egg to be released maybe 24, 36 hours after. So again, we don't want to rush. We want to wait. We want to be able to try at the appropriate time.
So when we come back from our break, we will now talk to you about how we manage patients that have some challenges in getting pregnant. So don't go anywhere. We're coming right back.
At Medical Associates Hospital, we offer minimally invasive laparoscopic cancer surgeries. This includes liver, gastric, colorectal, pancreatic, and gynecological surgeries. Let's fight cancer together. For further information, call us today, 462-2092. Medical Associates Hospital, #1 comprehensive and internationally accredited hospital in the Caribbean.
Welcome back to Medical Associates Health Check. So, Prof, we want to get into our treatment strategies for infertility. How do you think about this, or what would be your way of prioritizing your approach?
Okay, thanks, Dan. So, Chris, we try to define the causes by going through, of course, the history, the examination, the investigations. You mentioned ultrasound, you mentioned testing for the tubes and so on. And we think of that table again with 4 legs. And the first leg of that table is about egg production. And one of the commonest conditions that we see nowadays that prevent egg production is polycystic ovary syndrome. People call it PCOS or PCOS. And this is a condition where the eggs are not being developed to their full potential and not being released. Now, that's a whole segment by itself, and maybe we'll come back to that. But I just want to mention that the other important thing is the age of the woman. So we know for a fact that after the age of 35, egg production decreases because the woman is different from the man. She is born with all the eggs that she will have for her life. So that's her quota. And as they're being used up and they are dying away as well, they die away from birth, and they are being used up with ovulation and so on, there comes a time when there's not enough eggs. And that is another reason that there's this egg production after a particular age. And we use the advanced age as above 35, which is a bit unfair and unkind to the woman, but it's really meant to give one a sense of focus on that aspect of it, because at the end of the day, there isn't much you can do about your age.
Yeah.
That's it.
Prof, how old is too old to get pregnant?
Well, Aisha, I know you were going to give me a question I couldn't answer. Yeah, that's amazing. Because who knows? But let me say one thing. If we are trying to treat women to become pregnant, one of the first things we have to bear in mind is what is the well-being of the child who might be conceived.
Okay.
So a woman who is, or a couple who are old, meaning above 50, 55, bearing in mind that that child at age 20 will have parents who are 75 and above, it is a little something to think about.
It's
So
an
there's the
ethical
well-being of the child is very important. However, in pure terms of treatment, there are so many options. So number one would be ovulation induction, because that's the most likely thing that's
Right.
not happening, because as we mentioned before, there aren't enough eggs
Mhm.
or egg quality is poor. So maybe we can push the ovaries to develop eggs, and therefore there are ovulation induction agents.
Yeah.
And these might be tablets, or more commonly, they are injectables. So what the tablets normally do is that they create an indirect form of production of something called follicle stimulating hormone. The injections are actually that hormone itself.
Okay.
So you can use higher doses and you can cause ovulation to occur. But women must be aware that if they're above the age of 40, success rates are not high, number
Okay.
one, but also there's a higher risk of an abnormality in the fetus.
Right. Yeah.
Yeah, and therefore there may well be need for testing for chromosomal
Abnormalities.
abnormalities.
Yeah.
The other important condition that we look at is the tubes. So are the tubes functioning or not? So we test for them, and therefore do we try to fix the tubes, or do we do something as that will bypass the tubes? And the commonest thing bypassing the tubes would be IVF, in vitro fertilization. But I just realized I hadn't answered your first question thoroughly, which is what about the ovulation? What
Yeah.
can we do about that? So people with polycystic ovaries need a little help to develop these eggs and release them. We know it's related to a condition called insulin resistance. So we tell patients, hey, you might have a history of diabetes in your family, for example, but there's something which prevents insulin from breaking down the carbohydrates in your diet. As a result, the body produces more insulin, and in that environment, ovaries don't work well. So we recommend decreasing carbohydrates. We recommend using a medication that will help insulin sensitivity, and that is called metformin. Yeah. It's a drug that's used for people with actual diabetes, and sometimes we give medication to do what we call ovulation stimulation. So we try to stimulate the ovaries to release the eggs. And finally, if there's polycystic ovary syndrome or PCOS, there is an option for burning these cysts, and that will activate the ovaries. Okay. So with the now, there's so much stuff, but I'm just going to stop at that point for ovulation. And then, of course, the tubes, as we mentioned before. Then you have conditions that may affect implantation, and one of them is uterine fibroids. So there comes a time when one has to determine, is it necessary to remove these fibroids? And generally, I would recommend something called a myomectomy, which is an operation to remove the fibroids. Now, there are other methods to deal with fibroids. One of them is where an injection is performed into the uterine vessels, yeah, and that will block the blood supply to the fibroids. The only thing about that one has to bear in mind is that the fibroids don't disappear. When you remove a fibroid, it's gone. If you use the method of stopping the blood supply, it's still there. And then finally, the man. What about the man? What about the sperms? How can we help? Because that army you're talking about needs to be generally more than 16 million sperm per milliliter of semen. So millions.
Milliliter of semen.
That's like,
We want up to at least 16 million.
wow.
Now, in normal circumstances, men produce many,
More than that.
maybe 100 million sperm. But the problem, well, one of the other problems, of course, are they swimming well? Are they of good quality? Are they misshapen? So there's something you call motility, which is how fast are they swimming, because they have to swim fast and forward. They must have what we call progressive movement. So they must be swimming to meet the egg and to penetrate the shell of the egg. And on the other hand, you have, sperms which are not formed properly. Because remember, if you're producing millions, it's like a conveyor belt.
Yeah.
So in any conveyor belt, there are going to
There will
be
have some
defective
deformities.
sperms. So these are the things that affect us being able to give a good check and to say, yeah, everything is good. Maybe there's something else, even though sperms are being produced, maybe they're not just right. And there are things we can do about that.
So, Prof, we mentioned briefly just a little while ago about in vitro fertilization, and I think we also look at artificial insemination, which is one of your specialties. Could we talk about that and what its role is in subfertile
Yeah,
persons?
absolutely. It's a very good question. First of all, let me just dispel a myth, which is that many persons, and the man in particular, are led to believe that if their sperm count is low, maybe I should take some testosterone.
Right.
Because isn't testosterone what a man is all about? Well, unfortunately, if you take testosterone, it sends a negative feedback to the hormone that is supposed to stimulate sperm production. So I want to just make a big plea to men: don't go looking for testosterone. I know some pharmacies might be willing to sell it, but do not take testosterone medication in order to boost sperm production. So the other thing is, what about insemination? So we normally do something called intrauterine insemination, commonly called IUI. Why would we want to do IUI? Well, we might do it if the sperm count is low. We might do it if the sperms aren't moving too fast. We might do it if the sperm quality is not so good. How does it help? Well, what happens is that the sperms are collected, taken to a specialty lab, and what they do is that they wash sperm in the lab, so they get rid of any debris and so on, because you could have some debris. They remove the dead sperm, and then they get these sperm to swim through what we call a gradient. It's like if you're trying to filter water through pebbles of different sizes. They would let sperm swim through these gradients, which are loosely packed at one point but densely packed at the other. So those who come out at the other side are the best.
Cream of the crop.
Absolutely. And then they would collect those and put them in a small quantity of fluid, and that is then inserted into the uterus. One of the things that this process does, because we are giving nutrient media, is that it helps to energize the sperm as well.
Okay,
So
nice.
we can actually increase the sperm quality in terms of fertility and in terms of motility. As motility means movement, of course. There isn't very much we can do about problems with sperm quality, meaning there may be abnormalities of the head, of the neck, of the tail, all various parts of the body of the sperm. So that's a little bit different, and this is where maybe IVF may come in,
Okay.
but in vitro
And
fertilization.
for the IVF part of it, that's where we would use, the eggs and the sperm, then implant it.
Yeah.
Nice. So, Prof, I'm really sorry, but that's all we have time for today.
Wow.
But it was really interesting, and we're very, very, very glad you decided to come on. Maybe perhaps in the future you might come back and talk about in vitro fertilization in some more detail.
Maybe, and I still think we have polycystic ovaries.
Oh, we could
And
spend
polycystic
ages
syndrome.
talking about
Yeah.
it.
Only because it's so topical.
I agree, and it's common now.
Yeah,
I think it used to be 10% of people. Now it's much, much more.
much more.
But thank you very much for listening. We will be back on our next segment soon, so stay tuned, and always feel free to communicate with us via our social media pages if you have any questions or any issues you'd like us to discuss. Thanks again. We'll see you next time.